So we are now going to the next chapter on pediatric surgery. This chapter is on pediatric surgery. So here and there we have discussed pediatric surgery topics all over the discussion, like in stomach, we have discussed congenital lymphotropic pyruvicinosis. In liver, we discussed extrahepatic biliary atresia, like that. We have covered in urology also most of the pediatric topics. So let us discuss the topics which are not covered anywhere else. So the topics which are not covered in any other system, I'm going to discuss in this chapter now. So let us first discuss the abdominal wall defects. So there are two important abdominal wall defects I want you to know. So first of all, there are two important abdominal wall defects. So this is the abdomen wall of the baby. The abdomen wall can be having two types of defect. In one defect, if you see, the defect is present in the abdomen with a covering membrane like this, with a covering membrane. Okay, it is a congenital defect in the development of anterior abdominal wall. But luckily, the baby is having covering with the peritoneum. The peritoneal covering is present, and amniotic membrane and peritoneal covering are present. So therefore, if you see, the bowel will be protruding in this covering. So the bowel will be protruding in this covering. This is known as omphalocele. This is known as omphalocele. Omphalocele, also known as examphalose. Also known as examphalose. Omphalocele or examphalose is the name for this condition. So in another condition, the abdominal wall is totally defective with no covering membrane. With no covering membrane, the abdominal wall is totally defective with the bowel protruding out in an angry-looking manner. Angry-looking bowel is seen outside. So this is gastroschisis. This is known as gastroschisis. So please don't forget there are two abdominal wall defects. One is omphalocele, another is gastroschisis. Omphalocele is examphalose. Gastroschisis is a defect in the abdominal wall with the protruding out of bowel with no covering membrane. So now if you see, in the first condition, I'm just telling you the differences between the two. In examphalose, the umbilicus is attached to the summit of the membrane. So the umbilicus is attached to the summit of the membrane like this. So the summit of the membrane. But in gastroschisis, umbilicus is seen to the left of the defect. So umbilicus is attached here, and the defect is in the right iliac fossa. The defect is, question usually comes in exam. In gastroschisis, where is the umbilicus attached? Umbilicus attached to left of defect. And otherwise, the defect is in right iliac fossa. Umbilicus is to the left of the defect. It is to the defect. Examphalose is usually associated with serious anomalies, cardiovascular anomalies, like septal defects. Usually they have septal defects. Like ASD, all those septal defects are seen in around 20 to 40% patients of examphalose. Whereas gastroschisis usually does not have cardiac defect, but they have one another interesting problem, that is intestinal atresia. So gastroschisis is one of the most common cause of short bowel syndrome in children. I told you, it is one of the important indication of small bowel transplant. It can cause intestinal atresia. It is the most common cause of short bowel syndrome in children. Okay, so there will be serious anomalies and there will be intestinal atresia. So examphalose is further divided into two types. They are examphalose minor and examphalose major. Minor will have a defect less than 5 cm. Major will have a defect more than 5 cm. Please remember this. So major is more problematic because in minor only small bowel comes out, whereas in major small bowel even liver can come out. Even the liver can come out. Very difficult to manage, difficult to close the abdominal wall. Whereas minor is, we can even wait and watch. Wait and watch also can be done for minor. So minor has good prognosis, major has bad prognosis. So among the two, minor has good prognosis, major has bad prognosis. Instead of doing a major operation, just strapping alone is enough for minor. Examphalose minor, just strapping alone is enough. But for major, surgical closure needed. Gastroschisis, immediate surgery needed. Okay, so it is characterized, both are conditions characterized by defect in abdominal wall. Gastroschisis, the defect will be how much? Size of the defect will be usually less than 4 cm. And the size of the defect will be usually small, less than 4 cm only. And through that, the abdominal wall contents will protrude out with an angry looking appearance. The bowel looks like an angry looking appearance. So these cases like gastroschisis and examphalose major needs urgent surgical correction, and we have to reduce the contents and do operation. So next important problem in pediatric is intestinal atresia. Intestinal atresia. In intestinal atresia, Bailey says duodenal atresia is most common, whereas other books says jejunal-ileal atresia is most common. Like Sabiston says jejunal-ileal atresia is more common. For NEET PG exams, I will request you to follow duodenal atresia only, because it is very clearly given very loud. Duodenal atresia is most common intestinal type of atresia, and I already told you about this topic. Duodenal atresia will have double bubble appearance. Jejunal atresia will have triple bubble appearance. Okay, will have triple bubble appearance. Now coming to duodenal atresia. In detail. So though I have discussed a few points in stomach chapter, here I'm going to discuss more points. So duodenal atresia is associated with Down syndrome, annular pancreas associated with malrotation of gut. So duodenal atresia is associated with malrotation of gut, annular pancreas, and Down syndrome. It is of the following types. The types of duodenal atresia. Type 1 is most common type, that is complete atresia. Please remember, complete atresia like this. The bowel is completely atresia like this. This is type 1. Type 2 is there is a fibrous cord separating. There is a fibrous cord separating between this guy and this guy. There is a fibrous cord separating. Okay, there is a fibrous cord separating the two ends. 3 is there is an incomplete or partial obstruction. Incomplete or partial obstruction is type 3. So complete atresia, the bowel is completely atresia is type 1, fibrous cord is type 2, type 3 is incomplete or partial obstruction. There will be some lumen. Some lumen will be present in type 3, some amount of lumen will be there. Incomplete or partial obstruction is type 3. In this, one important atresia type you should know is Wind-Sock deformity. Wind-Sock deformity is a type of atresia. Wind-Sock deformity is a type of atresia. There is a mucosal web, please remember. So this is nothing but a mucosal web. It is a mucosal web like this with intact muscle. There is only a mucosal web like this with intact muscle. So the muscle is good, but there is a mucosa alone looks like a web. So it is a mucosal web with an intact muscle. It is known as Wind-Sock deformity. I will show you the picture. Intact muscle is present. So for a duodenal atresia, I already told you the treatment of choice is duodenostomy. In duodenal atresia, what is the presentation of the babies? 80% will come to you with the bilious vomiting, and 20% will come to you with the non-bilious vomiting. So non-bilious vomiting means the probable reason is the atresia is proximal to the ampulla. So 20% comes to you with the non-bilious vomiting. The atresia is proximal to the ampulla. So please don't forget the duodenal atresia. Don't forget duodenal atresia. Next I'm coming to jejunal-ileal atresia. The next one is jejunal-ileal atresia. It is 1 in 2000. It is 1 in 2000. It is usually follows some intrauterine mesenteric accident. So intrauterine, the baby is in the uterus itself. The blood vessels, there is some mesenteric ischemia happened. Mesenteric ischemic happened during the intrauterine period itself. Like a vascular insult has happened. So vascular accident, some blood supply to the small bowel has gone. That has resulted in atresia. Usually this is associated with cystic fibrosis. So duodenal atresia associated with Down syndrome. Jejunal atresia associated with cystic fibrosis. Please don't forget associated with cystic fibrosis. The types of jejunal atresia are type 1. That is a mucosal web. That is a mucosal web. Type 1, that is mucosal web. Type 2, that is a mucosal web is type 1. So in the side, I'm drawing like a thing. This is small bubble. In small bubble, there is a mucosal web alone is type 1. In type 2, there is separation like this, but there is a intact mesentery scene. There is an intact mesentery scene like this. Type 2, there is intact mesentery scene. Type 3, there is a gap in the mesentery. Please remember, there is a gap in the mesentery like this. V-shaped gap in the mesentery. There is a V-shaped gap is present in the mesentery is type 3. So type 3 is V-shaped gap in the mesentery. 2 is there is an intact mesentery. Though there is a separation of the bubble, atresia is present, there is an intact mesentery. 3 is having V-shaped defect. And this question is expected. 3B is a super specialty MCQ. Also asked in AIMS. It is the proximal bubble is coming like this. There is atresia. The distal bubble looks like this. What appearance is this? The distal bubble is having an appearance of apple peel appearance. Apple peel appearance, also known as Christmas tree appearance. So apple peel or Christmas tree appearance is type 3B. And this bubble receives blood supply from ileocholic artery retrograde way. From ileocholic artery, blood comes to the distal bubble in a retrograde way. So apple peel or Christmas tree appearance is 3B. 4 is the bubble is looking like a sausage shaped, multiple atresias, like a sausage shaped. Sausage shaped, multiple atresia is 4. So please don't forget, jejunal atresia is type 1 mucosal web. 2 with an intact mesentery. 3 V-shaped defect. 3B is apple peel or Christmas tree appearance. Apple peel or Christmas tree appearance. 4 is sausage shaped. 4 is sausage shaped. Please don't forget these points. Apple peel appearance. The bubble, distal bubble receives its blood supply from ileocholic artery. So jejunal atresia, we have to dissect the atresia segment and anastomose the normal segments. Okay. So we have discussed number 1, abdominal wall defects. 2, intestinal atresia. Now third, we are going to one of the interesting topic, congenital diaphragmatic hernias. So all topics in this chapter are very small topics only. So congenital diaphragmatic hernias. This is not acquired hernia we are discussing here. We are going to discuss congenital hernias. So this is a diaphragm, this is vertebra. So this is a posterior surface. So there are 2 important defects you should know. Anteromedially, congenitally we can have a defect. What is this defect? What is this defect? Anteromedially, there is a defect in anteromedial place in children. What is it? This is known as Larry's space. Anteromedially, the defect is known as Larry's space. Similarly, posterolaterally we have congenital defects like Bogdalak space. This is Bogdalak space. So there are 2 spaces congenitally seen in newborn babies. Through the Bogdalak space, we can see the bubble from the bubble of stomach or something contents from the abdomen will enter inside the chest through this defect. And this hernia is known as Bogdalak hernia. Bogdalak hernia is most common on left side posterolaterally. Please don't forget it is most common on left side posterolaterally. Bogdalak hernia is common on left side posterolaterally. It is common on left side posterolaterally. And the most common content is stomach. Most common content is stomach. So this is the overall most common type of diaphragmatic hernia. Overall, the most common type of hernia is left side posterolateral. Stomach is going in. That is the most common. So if a herniation happens through the Larry space, it is what? It is known as Morgagni hernia. It is known as Morgagni hernia. Morgagni hernia is seen most commonly right side anteromedially. It is seen right side anteromedially. Please don't forget this. So Morgagni hernia is a hernia seen right side anteromedially. And the most common content going is transverse colon. So in a Morgagni hernia, the common content going inside is transverse colon. So usually Morgagni hernia is very rare. It is common on right side anteromedial. Bogdalak hernia is common left posterolateral. Now if you see these 2 hernias, Bogdalak and Morgagni hernias, whatever may be the hernia, the baby on birth presents with what clinical feature? At the moment the baby is born, the baby will have difficulty in breathing, and when you keep a bag and mask ventilation, they will have more difficulty in breathing. So please remember, bag and mask ventilation is contraindicated. We should immediately intubate these babies. When you take X-ray chest, we can see the bowel contents in the chest. Bowel contents are present in the chest. So when you take an X-ray chest, the bowel contents will be there in the chest. So immediately intubate the babies and resuscitate the babies. So rise tube, when you put for these babies, rise tube will be there in the chest. These are all some catch points to know the baby is having congenital diaphragmatic hernia. Rise tube, it will be there in the chest. The bowel contents will be there in the chest. So these cases we have to put intubation immediately. Further prognosis of this baby after intubation and connecting to a intermittent positive pressure ventilation is connected. The prognosis of this baby depends on what? Very important MCQ. What is it? Depends on pulmonary hypoplasia. How much the lung is hypoplastic. So further prognosis depends on pulmonary hypoplasia. Anyhow, we intubate the baby and we wait for 24 to 48 hours. In 24 to 48 hours, the baby will recover, hypoxia decreases, and the baby enters a phase known as honeymoon phase. After 24 to 48 hours, the lung will expand and the baby goes for a honeymoon phase. At that time, you have to approach trans-abdominally. Please remember this. The approach is trans-abdominal approach. We should go and repair the defect and repair the hernia. So this is about the congenital diaphragmatic hernia. You should go trans-abdominally, go and keep a mesh and repair the defect. So please don't forget Bogdalak hernia and Morgagni hernia. The 2 important hernias I want you to remember for your exams. So Bogdalak and Morgagni hernia. So very important topic for your exams. Please don't forget. Now coming to the next important topic in this chapter, cleft lip and cleft palate. Cleft lip and palate. I'm going to discuss about cleft lip and cleft palate. So please understand the diagram I'm drawing here. Very important to understand this chapter. This is the lip, upper lip. I'm drawing the upper lip. This is upper lip and this is alveolus. Just think this is upper lip. The gums is nothing but alveolus. After that you have the hard palate. This is hard palate. After the hard palate, what comes inside? You can just palpate with your tongue and see what is that. It is usually soft palate. This is soft palate. So please understand, this is soft palate, this is hard palate, this is lips, and in between there is alveolus. So alveolus, soft palate, hard palate. Now you can see we can congenitally see some problem in the fusion of this palate and lips. That is known as cleft lip and cleft palate. So if you see, if only the lip is cleft, it is known as isolated cleft lip, isolated cleft lip, isolated cleft lip. If only the palate is cleft like this, it is known as isolated cleft palate. Only the palate is cleft, it is known as isolated cleft palate. If both these guys are cleft like this, it is known as combined cleft lip and cleft palate. There are three conditions which you can get in your practice. So combined case of cleft lip and cleft palate, isolated cleft lip, isolated cleft palate, isolated cleft palate, isolated lip. So which is common among this? So that's the question. Which is common among this? So combined is more common. Please don't forget, combined is the most common. It is seen in 1 in 600 people. So combined is more common. It is seen in 1 in 600 newborn babies. Combined cleft lip and cleft palate. So isolated lip is the rarest one. It is very rare. It is only 15%. Among the three, it is only 15%. Combined is 45%. Isolated palate is only 40%. So isolated palate alone is 40%. Combined lip and palate is 45. Lip alone is 15. If you see, interesting point is this: combined cases are common in men. Combined cases are more common in men. Isolated palate alone is common in women. So isolated palate alone is common in women. Combined cases is common in men. Combined. So please remember this picture. Very interesting point. If you know this, you can get on MCQ. So please remember, combined cleft lip and cleft palate combined is most common, and it is most common in men. Isolated cleft palate alone is common in women. It is the second common type. Rarest type is having only lip is cleft. Only lip is cleft is rare type. So when you do investigation, antenatal ultrasound can detect only what? Antenatal ultrasound will detect this. It can detect only cleft lip. It cannot detect cleft palate isolated cases. Cleft palate isolated cases cannot be detected. Only cleft lip isolated cases can be detected by antenatal ultrasound. So now tell me, what are the causes of this condition? It is usually due to maternal exposure to drugs like phenytoin, anti-epileptic drugs, maternal exposure to drugs like phenytoin, drugs like steroids, drugs like diazepam. So maternal exposure to phenytoin, steroids, or diazepam are due to some syndromes. What are the syndromes causing this condition? 100 times expected question. The most common syndrome associated with cleft lip and cleft palate is Peary-Robinson syndrome. Please don't forget. Peary-Robinson syndrome. Peary-Robinson syndrome is characterized by glossoptosis, retrognathia, and respiratory difficulties. Glossoptosis, retrognathia, and respiratory difficulties. So this is Peary-Robinson sequence or Peary-Robinson syndrome. Is the most common syndrome associated with cleft lip. Other syndromes are Down syndrome, Treacher-Collins syndrome, and we have Sprinson syndrome. Treacher-Collins, Downs, Stickler. All these are very rare syndromes. Please don't forget Peary-Robinson in this. In this, I want you to remember Peary-Robinson syndrome. So Peary-Robinson syndrome is associated with glossoptosis, retrognathia, and respiratory difficulties. Okay, please don't forget Peary-Robinson syndrome. And what are the clinical features? These babies present with cosmetic ugly looking. It is cosmetically ugly looking. The babies may have speech problems. They may have feeding problems. The baby may aspirate. Feeding problems, and they may develop mid-ear infections. So the clinical problems associated with this cleft lip can be cosmetically ugly looking. The speech problems may arise, feeding problems will be there, and middle ear infection may be there in these children. So therefore, please understand what you mean by complete cleft and incomplete cleft. I want you to know complete cleft means what? Incomplete cleft means what? Incomplete cleft means what? So if I'm drawing now like this, I'm drawing like this. Let's assume this is a nose, this is eye, this is a upper lip, this is lower lip. Now I'm drawing a picture. There is a defect in the hard palate like this. So the cleft palate is due to failure of fusion of palatine shells. It is due to failure of fusion of palatine shells. On this failure of fusion, if the cleft palate is attached to the vomer bone will be here. No, if it is attached to the vomer bone or nasal septum, the cleft is attached to the nasal septum. It is known as attached is known as incomplete. It is not attached is known as complete. So please remember this point. If it is attached, it is known as incomplete. Not attached is known as complete. So the cleft attached to the vomer is known as incomplete. Not attached is known as complete. Now with these things, we have so many classification systems which are used. One of the commonly used classification system from Bailey and Lau is La-Shaw classification. La-Shaw classification system, also known as Talbot's. La-Shaw or Talbot's classification. So La-Shaw classification system or Talbot's classification system. So what is this La-Shaw or Talbot's? So it stands from right to left. The La-Shaw, the word stands from the patient is sitting in front of you, right to left. I'm writing from right to left. So for example, this is the patient in front of you. This is soft palate, this is hard palate, this is gums or alveolus, and I already told you this is the soft palate. This is soft palate. Now I'm going to show you what is La-Shaw. If there is a cleft lip, cleft alveolus, cleft hard palate, cleft soft palate like this, and opposite side also there is cleft hard palate, cleft alveolus, cleft lip like this. So everything is complete or incomplete. We have to see. If everything is complete, it is given the mnemonic short term as La-Shaw. So L stands for lips, A stands for alveolus, H stands for hard palate, S stands for short palate of right side. And another H stands for left side hard palate, another A for left side alveolus, another L for left side short palate. So La-Shaw means it's a complete cleft lip, cleft palate, both sides. If I'm writing it as LAH small h and I'm writing it as capital SH, what does it mean? So on the left side there is partial cleft lip, cleft alveolus, cleft hard palate. So partial or incomplete. On the left side, on the right side it is incomplete, partial cleft lip, partial hard palate, partial hard palate. And then comes left side complete short palate with hard palate. But there is no alveolus or lip on the left side. On the left side, there is no involvement of lip or alveolus according to this La-Shaw. If I tell it as La-Shaw, if I tell it as La-Shaw in all small letters, what does it mean? All are incomplete. If I tell everything as small letter, all are incomplete. Bilateral, but all are incomplete. If I tell in capital letters, it is bilateral, all are complete. So this is classification system in Bayesian law, you have to know. Classification system, one more is Kernaghan's classification. Kernaghan's classification of cleft lip and cleft palate. In this, we draw the diagram like this. In this, we draw the diagram like this, known as Kernaghan's. And we give numbering from 1 to 9. We give numbering from 1 to 9 numbers are given. Okay, based on these numbers, we name it as by 1, 2, 3, 4, 5, 6, 7, 8, 9. Like this, the numbers are given. And based on the numbers, 4 stands for lips. Same like last 4 stands for lips. S stands for alveolus. 6 stands for hard palate. 7, 8, and all will stand for soft palate. If I'm telling it is 4 means there is an isolated cleft lip on left side. Isolated cleft lip on left side. So like that, Kernaghan's is another classification, not asked for PG exams. Just remember the names. Kernaghan's is another classification asked for PG exams. Okay. So now comes a very important point. When are you going to operate these guys? Operation of these guys. Timing is very important. So usually in PGME exams, they will ask you the timing of each operation. Timing of this operation. They will ask you the timing of the operation. If patient is having only cleft lip, let us assume patient is having cleft lip and soft palate only. There is no hard palate, only cleft lip and soft palate. What I'm going to do? If it is cleft lip, short palate, unilateral. If it is cleft lip and short palate, unilateral, we can do at 6 months. We can do surgery at 6 months. Single time surgeries, one surgery, single surgery at 6 months. If it is unilateral cleft lip and soft palate, single surgery that can be done in 6 months. If it is bilateral cleft lip and bilateral cleft soft palate, one surgery done at 4 to 5 months on one side, another side we do it at 6 months. So two surgeries are done for bilateral cleft lip and soft palate. If the defect is only soft palate only, we can repair it at 6 months. That's all. So please don't forget, cleft lip with soft palate, unilateral, one operation 6 months. Bilateral cleft lip, bilateral soft palate, one operation at 4 to 5 months, another operation at 6 months. Whenever there is bilateral, we should do 2 operations because we cannot operate both mouths at the same time. The baby cannot even swallow milk on one side, so we have to operate 2 times. Bilateral cases needs 2 times surgery. Okay, now for combined cases of soft palate and hard palate, what I'm going to do? Combined cases of soft palate and hard palate. Please remember, soft palate and hard palate. What I will do is, soft palate I will operate at 6 months. I will operate at 6 months. Hard palate I will operate at 15 to 18 months. Okay. So when will I operate soft palate? One soft palate I will operate at 6 months. Hard palate I will operate at 15 to 18 months. Only for combined soft palate and hard palate. If there is combined all cleft lip plus cleft soft palate plus cleft hard palate, what I am going to do? How many operations I will do? So combined soft palate and hard palate, I did 2 operations. For a cleft lip with a cleft soft palate with a cleft hard palate, I will do 2 operations. Cleft lip and cleft soft palate operated at 6 months. Cleft hard palate operated at usually 15 to 18 months. So in this, the point I want to remember is hard palates will take some time to develop. The bone will take some time to develop. So usually hard palates are operated at 15 to 18 months. Soft palate is operated at 6 months. Okay, 6 months. So lip soft palate at 6 months. Hard palate at 15 to 18 months. What are the name of the surgeries? Name of the surgeries. So what are the name of these surgeries? What we are doing? So cleft lip, what is it? Cleft lip operation is known as Millard operation, Mulliken operation. All these are various names. Millard, Mulliken, Manchester. 3M operation. Millard, Mulliken, Manchester are the various operations for cleft lip alone. For cleft soft palate, we have furrow operation, Furrow's technique. And usually the question asked in exam is only for cleft hard palate. Usually the examiner's question is from cleft hard palate. Cleft hard palate, we do Wardell and Langenbach procedure. Wardell and Langenbach procedure. At what month? 15 to 18 months. Wardell and Langenbach procedure. Wardell and Langenbach repair. Okay, so name the operations they can ask you, especially this Wardell and Langenbach, they can ask you. Furrow is for soft palate, Millard, Mulliken, and Manchester for cleft lip. So these are the various name of surgeries we do. Are this. And there was a old rule known as rule of 10. It is no more there. In those days, this ideal time of operation was not given. Therefore, they used to operate at 10 weeks baby, minimum 10 pound, 10 weeks baby, 10 gram hemoglobin. They used to operate, old surgeons. So rule of 10 was used in cleft operations in those days. So this rule is no more because soft lip, lip and soft palate we operate at 6 months, hard palate we operate at 15 to 18 months. Okay, so I would like to show you the images now. And what are the complications of these operations? After this operation, what complications can happen? The main complication or the most common complication is velopharyngeal incompetency. The most common complication is velopharyngeal incompetency. The patient is unable to speak properly. There is a velopharyngeal incompetency. They will have a nasal twang in the speech. They will have speech problems, hearing problems. They may develop a oroantral fistula. Hearing problems will be there. Oroantral fistula may be there. And because of poor development, this mouth upper lip can become like a cupid bow deformity. Okay, the upper lip can become like a cupid bow because of poor development. So these are all acute complications: cupid bow, oroantral fistula, speech, hearing difficulties. But secondary problems are usually speech problem, hearing problem, dental problem, facial growth. All are affected. Facial growth, dental problems, hearing problems, speech problems. All these problems can happen as secondary problems in a patient. Okay, all these can happen as secondary problems in these patients. So these are the basic points you have to know in cleft lip and cleft repair. Let me show you what are the topics we have discussed so far. Let us show you the topics we have discussed so far. So please remember, this is a typical image-based question. Many times asked. You can see the ampulocele with the umbilical cord attached to the center. See, you can see the umbilical cord attached to the summit of the membrane. Gastrospices, you can see an angry-looking bowel with the intestinal atresia. Classical intestinal atresia will be there. And usually, if you see, the defect is to the right of umbilicus. This umbilicus will be here, and the defect is seen in the right iliac fossa like this. Okay. So intestinal atresia, you can see the types of duodenal atresia. Type 1 complete, type 2 will have a fibrous cord, and type 3 is partial obstruction. This is a typical Windsorf deformity seen in duodenal atresia. One type of duodenal atresia full of mucosal web is Windsorf deformity. So jejunal ileal atresia, this is a picture taken from Sabiston. Type 1 is there is a mucous web. Type 2 is fibrous cord. Type 3 is blind end with a V-shaped defect. Type 3B is apple peel appearance. And you can see the typical apple peel appearance. These cases of distal bowel will now receive blood supply from ileopolic artery. Typical apple peel appearance. You can see the apple peel appearance. So diaphragmatic hernias, I told you left side posterolateral is most common, and the most important prognostic factor is the hypoplasia. You can see the huge defect on the left side with the stomach, everything will go inside. Most commonly stomach goes. So cleft lip and cleft palate, please don't forget, this is a typical cleft palate. You can see there is a complete cleft palate. The cleft is not attached to the vomer, is complete. Not attached to the vomer, is complete. This is large shell classification. Lip, alveolus, hard palate, soft palate, large shell. Okay. And similarly, Kernaghan's classification will have numbers 1, 2, 3, 4, 5, 6, 7, 8, 9, up to 9 numbers are there. We will mention the defects in terms of numbers. So ideal time of surgery, please don't forget all the points I told you. This is a technique known as Mulliken technique of repair of cleft lip. Mulliken, what are the other techniques? Mulliken, Millard and Manchester. Mulliken, Millard and Manchester. And for soft palate, the repair is Furrows repair. You can see the soft palate repaired by Furrows method, Furrows technique. Hard palate repaired by, soft palate is Furrows, hard palate repaired by, what method is this? So this is a classical method showing you there is a defect in soft palate as well as hard palate. They are approximating it by Wardell and Langenbach operation. Wardell and Langenbach operation. Please don't forget this operation. Wardell and Langenbach operation. Okay. So now the complications are below-pharyngeal problems, excessive nasal tones, speech and hearing problems, orovantral fistula. All these are various complications seen. Okay, now let me discuss what are the various ideal time of operation, ideal time of various surgeries. Okay, ideal time of each surgery we are going to discuss. First, let us discuss in pediatric surgery, when should you operate? Urology operations in pediatric surgery. Congenital hernia, when will you operate? Congenital hydrocele, when will you operate? Hernia, there is high chances of obstruction in babies. So the moment you diagnose, as early as possible, because it's a narrow canal, it can get obstructed very commonly. As early as possible. Hydrocele is operated at 2 years. So please remember, hydrocele is operated at 2 years. Hypospadias, 6 months. Undescended testis, 6 months. So undescended testis and hypospadias are operated between 6 months and 1 year. Phimosis, congenital tight phimosis, we operate at 1 to 2 years. Congenital tight phimosis, we operate at 1 to 2 years. So these are the urological operations. When will you operate? Next, coming to gastro surgeries. Gastro surgeries, what are the operations you do in gastro? So congenital diaphragmatic hernia, when did I tell you? 24 to 48 hours, you have to delay. So after 48 hours, usually we operate in the honeymoon period. Extrahepatic biliary atresia should be operated before 6 weeks. Can you tell me what is operation done for extrahepatic biliary atresia? What is operation? Kasai procedure. Kasai procedure. When will you operate congenital hypertrophic pyloric stenosis? Usually at 4 weeks. What is the name of the operation? Ramstad's pyloromyotomy. What are the pediatric surgery? Midgut volvulus. Midgut volvulus is operated at the earliest, immediately. What is the name of the operation? That is Lad's procedure. The last operation we do in pediatric is usually an umbilical hernia. We have to wait for up to 5 years. Please don't forget. Umbilical hernia, we wait for up to 5 years. If the umbilical opening is not closing by 5 years, we operate at 5 years. The last operation is at 5 years in umbilical hernia. Many babies will have their umbilical hernia closed. Okay. And what are the other operations? Head and neck operations. Head and neck, cleft lip, soft palate, hard palate. 6 months, 15 to 18 months. Okay, 15 to 18 months. Cystic hygroma in the neck is operated after birth. It is operated after birth. Cystic hygroma is operated as after the birth of the baby. So this is when we operate each problem, when we operate each disease. So please don't forget Lad's procedure for midgut volvulus, Ramstad's pyloromyotomy for congenital hypertrophic pyloric stenosis, Kasai procedure for extrahepatic biliary atresia are the various operations we do. Please don't forget these points. And next, coming to the pediatric oncology. The last topic in this chapter is pediatric oncology. Pediatric oncology. So this is direct one-liner question topic. What is the most common cancer in childhood? Most common cancer in childhood. It is blood cancer, leukemia. Please don't forget it is leukemia. The most common cancer in childhood is leukemia. After leukemia, the second most common is, or otherwise, what is the most common solid tumor? The most common solid tumor is nothing but brain tumor. The most common solid tumor, or the second most common tumor, is brain tumor, and usually it is astrocytoma. Astrocytoma grade 1. Okay, what is it known as? It is known as pilocytic astrocytoma is the most common brain tumor in children. Pilocytic astrocytoma or grade 1 astrocytoma is the most common solid tumor or the second common tumor in children. What is the most common abdominal tumor? Most common abdominal solid tumor. Abdominal tumor, most common abdominal tumor or most common extracranial solid tumor. So the question can be in different ways. Most common extracranial solid tumor is, yes, what is it? It is neuroblastoma. Please don't forget it is neuroblastoma. Neuroblastoma is most common abdominal mass in children, more common than Wilms tumor. Wilms tumor is not that much common like neuroblastoma. Neuroblastoma is more common. Okay, please don't forget this. And most common malignancy in children less than 1 year. Most common malignancy in less than 1 year child is neuroblastoma. So neuroblastoma has two MCQs. In pediatrics, the most common abdominal tumor is neuroblastoma. In infant, overall, the most common tumor is neuroblastoma. Please don't forget neuroblastoma. And most common soft tissue sarcoma. Most common soft tissue sarcoma in children is rhabdomyosarcoma. It is rhabdomyosarcoma. Rhabdomyosarcoma. And most common renal tumor in childhood. Most common renal tumor in childhood is, please remember, it is congenital mesoblastic nephroma. Congenital mesoblastic nephroma. Congenital mesoblastic nephroma is more common than Wilms tumor. It's more common than Wilms tumor. So mesoblastic nephroma is more common. So which is a tumor in children which can produce huge number of mets? Most common pediatric tumor to produce mets. What is the most common pediatric tumor to produce mets? It is neuroblastoma. Very interesting point. Neuroblastoma is the one which causes severe bone mets. They produce bone mets, especially to the long bones. So most common mets is to long bones. Long bone mets are seen. So pediatric oncology, please don't forget these points. Overall, the most common tumor is leukemia. Second common tumor or solid tumor is brain tumor, which is pilocytic astrocytoma. Abdominal tumor is neuroblastoma. Most common malignancy less than 1 year is neuroblastoma. Soft tissue sarcoma is rhabdomyosarcoma. Most common renal tumor is congenital mesoblastic nephroma. And what is the tumor which produces severe mets is neuroblastoma. Okay, coming to neuroblastoma. Little detailed explanation of neuroblastoma let us have now. So neuroblastoma arises from sympathetic chain. It arises from sympathetic nervous system. Sympathetic nervous system, most commonly from adrenal medulla. It is mostly from adrenal medulla. It arises in around 38% cases. Or it can arise anywhere along the sympathetic chain, like in the paravertebral region, in the aorta. Paravertebral region, it can arise in the chest. The chest is 20%, paravertebral region is 30%, and rarely in neck and pelvis. So these are the various sites of neuroblastoma. In this, I'm going to discuss about the neuroblastoma in the abdomen. It is usually seen in the age group of 1 to 5 years. Neuroblastoma is commonly in the age of 1 to 5 years. They present to you with a clinical feature of abdominal mass. They present to you either as abdominal mass or as bony mets. So they present to you either as an abdominal mass or bony mets. The interesting point is 70% of them have mets on presentation. 70% will have mets on day coming to hospital. So they have so many issues like mass in the abdomen. They have bone pain, painless bluish skin metastasis will be there. Like what are the metastasis? Bone mets will be there, skin mets will be there. Okay, there will be paralysis. All these things are seen on clinical presentation of neuroblastoma. So the important differential diagnosis is if a baby comes to you with a huge mass in the abdomen like this, it can be a neuroblastoma or a Wills tumor. How to differentiate? Neuroblastoma is more common. The points favoring neuroblastoma. What are all the points favoring neuroblastoma? So neuroblastoma is more common. Neuroblastoma has calcifications. It will have calcifications. Neuroblastoma cross the midline. It will cross midline. It will invade the spinal cord. It will invade the spinal cord. It will produce extensive mets are present in neuroblastoma. It can invade the spinal cord. It has elevated urinary VMA. Vinyl mandelic acid is elevated. So these are all points favoring neuroblastoma. Neuroblastoma is not confined to one side. Wills tumor is confined to one side. Neuroblastoma crosses midline. It infiltrates the spinal cord and the nerves. Whereas Wills tumor will invade the veins. Neuroblastoma has mets and VMA is positive. And one interesting finding on IVP in these cases is the kidney maybe this is a kidney means the tumor is here, no? So it can push the kidney and the kidney will go to this appearance. And on IVP you get an appearance known as water lily appearance. Drooping lily appearance. The appearance is known as drooping lily appearance seen. There may be drooping lily appearance seen in neuroblastoma. So please don't forget this drooping lily appearance can be asked as an image-based question. IVP shows drooping lily appearance in neuroblastoma as well as in another condition. Where is it? Urology question. Ectopic ureter. In ectopic ureter and in neuroblastoma, we have drooping lily appearance. On investigations, we have elevation of VMA, there will be elevated VMA, vinyl mandelic acid, there will be elevated homovenilic acid, elevated, and there will be dopamine elevated, noradrenaline will be elevated. So all these are elevated on urinary investigations. On urinary examination, there will be biochemical examination of the urine will show elevated VMA, HVA, and dopamine and noradrenaline will be elevated. Accurate diagnosis is possible with the help of CT or MRI. We have to take biopsies. Okay, so that is one classification system of this tumor. Though not so important, just know the name. International neuroblastoma staging system. The staging system is International neuroblastoma staging system. Is a staging system available for neuroblastoma. And the treatment is for low risk cases, surgery alone is enough. For low risk cases. Intermediate risk cases, we have to do surgery plus we have to give chemotherapy also. So low risk cases surgery alone, high risk cases we should do surgery plus chemotherapy. Chemotherapy may include carboplatin, cyclophosphamide, etoposide, all those things are given. And high risk cases will need so many treatment like multi-agent chemotherapy plus stem cell therapy. All are given. Anyhow, the 3-year survival is less than 30% only in high risk cases. The survival is less than 3 years only. So please remember neuroblastoma for your exam. So neuroblastoma is one of the important topics. It's one of the pediatric tumors common in the age group of 1 to 5 years, and the most common tumor less than 1 year is neuroblastoma. Please don't forget. So international neuroblastoma staging system is there, which is not asked in exam, so I'm not going into it. So just remember there is a staging system known as neuroblastoma staging system by international. So these are the points I want you to know in this chapter. Please don't forget these points. Okay, thank you.